from the LICSW Podcast Network.
Hi, everyone. Excited to be here today, and welcome to the Burnout Antidote, infusing well-being into healthcare culture. Now that's a title for you. I'd like to talk today with my colleague, Paul Deger, about why we're the podcast you should listen to and what we can do to help you through all of these challenges in healthcare.
Hey, Amy, good to be here with you. And, the why. Why are we talking about this? I took a look at some of the data out there about what's going on in healthcare and healthcare clinicians. From a 2021 survey, I found that 38% of healthcare workers are reporting anxiety and depression, 43% are suffering from work overload, and 49% reported burnout. Individual groups like physicians or nurses, some of those numbers are even higher. Even our medical students are suffering. They report depression 15 to 30% higher than the general population. And to make it even more sobering, when it comes to thoughts of suicide, 1 in 10 medical students report having some degree of suicidal thoughts, 1 in 4 interns, and 1 in 16 practicing physicians. We have got our work cut out for us, Amy, to open up a conversation here about what is the reality and what we can do about it within our healthcare cultures and environments.
Thanks, Paul. In addition to sharing those numbers, I really feel like this is more about the feeling or more about the stories or the compassion that we have for ourselves as we are going through this. These numbers are sobering is a good word for it. But I think the more we hear stories about this, the more we think about what can we do to respond. And as you will hear today and in future episodes, some of this is how can we be to respond in addition to what can we do. I'm Amy Pearlman, a clinical social worker, and I lead clinical innovation at LICSW. My background clinically is in emergency services or mobile crisis services. I've worked in inpatient, outpatient, and substance use disorder settings. And I think as these numbers come across, we usually have this idea of us and them. We're talking about the numbers with the people that we serve, but not necessarily talking about the numbers or the experience or what it's like for us as the clinicians who are delivering these services. So as daunting as the task may be, Paul, I am excited to jump in and figure it out together, as imperfect as it may be.
Yeah, let's do this. So I'm Paul Deger. I'm the clinical director here at LICSW, and by training, a licensed professional counselor and a physical therapist. I've been in this world of healthcare for 35 years now, and oh my goodness, have things changed. And I really feel like these are our peeps, Amy. I feel like I want to give back because I know they're struggling and suffering. I've experienced healthcare inpatient and outpatient work, psychiatric medical settings, home-based teams, case management, sort of been all over the place. And I really have seen the world changing. Now, COVID, whole nother influence to everything that was already going on. But I think what we're going to talk about today was around before COVID. And I know I opened up with a bunch of stats, but ultimately, this podcast is about stories, hearing from the folks doing the work. What are they experiencing? They're suffering, they're struggling, and also hearing a way through and a way out. So I'm just excited to be partnering with my buddy Amy here and exploring this topic and hopefully giving folks a chance to be seen and heard.
We've asked several healthcare clinicians what burnout means to them. And we really want to value what their answers were and their experience in terms of informing our conversation.
I think burnout is an inappropriate word to use to describe all the experiences that come with the feelings of burnout. I do like moral distress better. I think it's more accurately reflective of what we go through. In the same vein, I'm not a big fan of the term resilience. Resilience suggests if only we were tougher, this wouldn't have happened to us. And I don't think that's the case. I think we're all very tough and this is a difficult field and we go through a lot.
For me, burnout is a feeling of constant and undirected anxiety. When the anxiety stops motivating me, but rather becomes overwhelming and loses its usefulness, I'm just left with a feeling of powerlessness and burnout.
Burnout for me is a situation where a healthcare professional has experienced such an overwhelming set of circumstances in the care of patients or in their interaction with their colleagues that either emotionally, spiritually, physically, they are exhausted. And as a result of that exhaustion, they have problems performing their job and interacting with colleagues or perhaps even members of their own family.
To me, burnout occurs when the joy and satisfaction of your work is eclipsed by administrative busy work and long, exhausting hours.
Burnout for me is essentially feeling a loss of passion for work. Generally it feels like an irritability with professional encounters, that come from that just chronic stress and a loss of passion for what I do.
Burnout to me is a form of detachment. I believe I feel detached from a career that I once thrived at, that I loved.
For me, burnout is just a state of profound emotional exhaustion where you compromise your ability to be empathic and adhere to medical ethical standards.
I feel that burnout is that moment in which work takes your personality and take every other characteristic that makes you valuable as a human being and just makes you feel as a tool to your work.
Amy, those stories just felt like a really good place to start, and hearing directly from the folks that we hopefully are giving back to in this podcast. When I listened to them, some words really jumped out at me that got repeated over hearing from the different folks. Words like powerlessness and overwhelming. And one word over and over again was loss. I kept hearing that the folks out there doing healthcare feel like there's a loss. I think of what they set out to do, what their initial passion was. And I just found that really touching, and all the more feeling called to, we gotta talk about this.
I did feel like the lived experiences made the case for us to do this, made me feel even more committed to having this conversation or to doing this work. I think it was an experience of hearing suffering. Mm-hmm. And also the other theme that I heard in these was really how widespread this is. It really started talking about how work was, I hate to say in a healthcare podcast, bleeding, but that is the metaphor that's sticking with me. But how this is kind of infusing, I guess, into other parts of healthcare clinicians' lives. And that certainly is what it has felt like to me as a clinician. So thinking about how does this affect who you are? How does this affect who you are in and out of work? Different kind of medical or physical components as well, with lack of sleep or changes in eating patterns. And that this is real. And it is suffering. And that's what I wanted to stick with.
Something else that also stuck out to me is looking at words. The one person who's kind of like the sense of, well, if you were just tougher, you got to toughen up. And it's like, I love the comment of we are tough. Healthcare folks with between training and work have been through a lot. And also starting to hear about, we got to change our words, that burnout really does not fit this experience. And this idea of resiliency is not the solution. It's almost insulting to say we got to be more resilient. And it does make me start to think we may need to change the words that we use when we're talking about this.
I can see that. And I see that not just in the conversation for the podcast, but in the way that I carry myself in general. The more I've read about this, the more I've heard people's stories, the more I think that I've got work to do here. So I'm happy to join this together with you, not as an expert, but as a partner in learning how to talk about this in the way, not that it's a right way, but how to talk about it in a way that truly honors what the experience is and gives a path out.
Yeah, honors is the word that came to mind for me too. Amy, I need some help here. And I think we need to bring in Dr. Thekla Ross, who is an expert in this area of burnout and moral distress, because I want to get a better understanding of things have changed in the past few years. I used to talk about this many years ago, and I want to get a better understanding of what are we taking on here. And so Dr. Thekla Ross is a clinical psychologist, certified ambassador of compassion, which I think is the coolest title I've ever heard in my life. I want to be one of those. A national leader of addiction medicine, and strengthens human resources for national abortion providers. So let's give Thekla a ring and get her input on this.
Let's do it.
Hi, Dr. Ross. I appreciate you taking some time out of your busy day to chat with Amy and I on this topic.
Hi, Paul. Hi, Amy. It's so great to hear your voices. Thanks for inviting me in.
So, Thekla, I'm going to jump right in. What is moral distress? Help us understand this concept, this term, when it comes to folks working in the healthcare world.
It's a great question, Paul. And gosh, has it changed over time? So, moral distress, it occurs when someone knows the right or moral thing to do, but institutional constraints, oppressive systems, structurally violent systems make it impossible to pursue the ethical course of action. So Jameson and some colleagues, they call it psychological disequilibrium. You know the ideal action, what honors the humanity of the person in front of you, but you can't carry out that action because of the institutional obstacles, or because of time, or because of lack of support, or power, or policy, or legal limits. The key kind of takeaway of this, Paul, is despite the institutional or systemic barriers, the distress is experienced internally by the person having to make the choice. So it occurs when the individual feels powerless to carry out ethical, appropriate actions. And I know you didn't ask me, but I'm going to go on and define moral injury while we're here because they're really correlated. Moral injury occurs when moral distress is experienced repeatedly over time and the effects are long lasting. And it has that aspect of powerlessness when you can't do the right thing. Maybe you did something already. Maybe you finished the task. Maybe you finished the encounter with the patient, but you didn't feel that sense of relief, like I helped him. You have this sense of like it wasn't enough. It's like you're running a marathon, but there's no finish line. Your knee hurts, you're exhausted, you're thirsty, you're hungry, but you have to keep going because the people who plan the event and the organization and the race say it's not over yet and everyone else is still running. And so you keep running, and that is injurious. That lack of acknowledgement, that lack of turning towards the suffering and the distress of not being able to do what you think is morally and ethically right.
When I was doing more clinical work in the field, we always called this burnout. And that's really when we started having these conversations, Paul and I, and thinking about how we would bring this into the podcast. Burnout is the word that comes up. Can you talk a little bit about why you are not using the word burnout?
Yeah, great question, Amy. And I love that you're playing around with it because how I may feel about it isn't necessarily how someone else may feel about it. So I'll go ahead and define how we talk about burnout sort of in the literature and in the culture. So Dr. Paul Deger says burnout is the manifestation in an individual of dysfunction in the system, in the workplace. So it's not the individual who's burnt out, it's the workplace that's dysfunctional. And I think it's important for us to just even name, like the World Health Organization has conceptualized what it means to be quote unquote burnt out in their ICD-10, their international classification of diseases. So it's feelings of energy depletion or exhaustion. It's increased mental distance from one's job and having like those sort of negative or cynical feelings related to your job. And it's really reduced professional efficacy, which is hard on any of us, right? We all want to thrive. We all want to have a sense of purpose and connection, especially all of us in healthcare who are really dedicated to the work we do. So burnout refers specifically to the phenomena in the occupational context. So it's not necessarily, it's being used a lot in other areas of life. And then the words stress and burnout are kind of being used interchangeably to describe sort of the global feelings. But it's a syndrome. So it's a group of symptoms that consistently occur together. And we can really say that they're shared experiences because there are a lot of people who are quote unquote experiencing it. So the part I would say to make clear is it's not the fault of the individual. It can't be seen in isolation. And it's not lack of resilience or individual weakness. I'm going to say it again. It's not individual weakness or lack of resilience. This is where our sort of individualistic culture has led us astray, I think. Often in the healthcare arena, burnout is addressed or seen as individual weakness, and there's all these individual self-care. We'll get into this later, and I think our conversation, sort of the laundry list of to-dos, of things that people have to do. And I think that denies the context in which the human being exists, which is within a system, within a culture, within an organization. And to quote Dr. Dechant again, it's that system that is dysfunctional, not the person itself.
I definitely want to jump into this self-care piece. But before that, I've been doing a deep dive in the literature to really understand what we're talking about here. And I have seen some pushback from clinicians around when you start to talk about this idea of use words like moral in it. And like, it's not moral, it's a lousy EHR I have to use, or it's, we're understaffed. I want to have an understanding of how to hold all this around the piece you mentioned about this almost sense of trauma where I know what I want to do and I can't do it versus some of these like practical institutional barriers. Can you help me understand that a little bit better?
Yeah, I'm glad you brought up the EHR because I see the moral distress of the EHR, the electronic health record. In my opinion, it directly challenges an aspect of compassion. And we call this aspect common humanity. So the need to connect face to face with the human being in front of you or virtually with you two right now, Amy and Paul, to let them know that they're not alone in their suffering. So the healing power of human connection is to know that you're not alone in this experience. But the EHR distracts from that. It puts documentation above human connection. It removes eye contact. It doesn't allow the provider to place their hand on their heart and express with their body language that I not only hear you, Paul and Amy, but I'm holding you on my heart and I'm with you. It really puts moral pressure on the provider that deeply wants to sit at the bed of the patient and be present with them somatically, with their tone of voice, with their body language. But it has the pressure of 21 patients scheduled that day, no additional time for documentation, a fear of legal ramifications or penalties if you don't document properly. To be honest, I feel like it's inhumane. We're asking our providers to be a machine and a human at the exact same time. It's kind of why I'm such a big fan of medical scribes, which are people who are scribing for the provider. So it lets the doctor focus on you and them and their own self-compassion, which we'll get into in a little bit, which is quite frankly allows them to be more present as healers when they can focus on their own self-compassion, the provider. The EHR has a role for sure, Paul. I'm not denying it. It's irreplaceably important in modern healthcare. It's quite frankly vital. But I'm just asking us as healthcare leaders and systems to be curious if the EHR, to be literal, the keyboard is in the right hands. Is the right person doing it? We know the COVID-19 pandemic introduced more sources of all of this, the moral distress for healthcare professionals. And there was this rapid shift from sort of patient-centered ethics to public health ethics, all of that at once. So, providers are having to stay up to date on rapidly shifting protocols, telling families they can or can't visit or cannot witness their family member dying. And having patients die alone is treating patients without proper protective gear. It's really abandoning this humanity that we want deeply, so deeply to do. And it places sort of protocols above everything else. And as we just said, that's really morally injurious and distressful. I think part of the systemic challenge is we haven't paused long enough to ask, where do all these electronic players sit in this relationship between two human beings? So we just put them in. We put in the EHR and we put in all these other things, and they're vitally important, do not get me wrong. But we haven't really examined the role of how they play in the relationship. And we know, think about intimate relationships. You add in another person or another thing into the dynamic and it shifts the relationship. I ask us to be curious about that. Where does all of this fit in the relationship between the patient and the provider or the patient and the family member?
What you bring up really resonates with me in terms of how it's easy to other this as a problem with if you're thinking about a child or you're thinking about an adolescent, really easy audience to feel compassion for. We do have less compassion for ourselves. And we have almost accepted this type of computer time or non-human connection as part of what doing business is. even if we're not in a virtual environment, really the amount of time you spend in front of a screen or with a keyboard is not the same as the amount of time you spend with a human. So I appreciate you awakening that thought for me.
That systems quality of we've got the cart before the horse, maybe. And right now we're in service of the tech, and it needs to maybe be the other way around, as well as our processes and protocols. I feel like I'm doing further confessions here. I used to teach these courses on burnout and self-care and resiliency. I feel like this is my my karmic correction for that, doing this podcast.
Us healthcare clinicians are driven to heal and help others. At PsychHub, we offer a wide variety of content that can support your well-being, help you find new creative and evidence-based ways to practice, and get inspired again. Whether you want to better understand depression, or you're interested in providing trauma-informed care, or you want to learn about navigating grief, our vast library of educational content has you covered. PsychHub offers curated continuing education learning opportunities on a variety of timely and relevant mental health topics and evidence-based interventions, geared specifically toward healthcare and mental health providers. These custom learning programs will empower you to support better mental health for patients, colleagues, and yourself. Learn more about our evidence-based mental health education opportunities at psychhub.com.
Can you speak a bit more about why self-care is not the solution here for this moral distress experience?
Paul, you're so sweet. And you have me thinking about how I somatically, because I know you resonate with this with your training from Naropa, of how I feel in my body when someone even just says the word self-care. I kind of I shudder a little bit inside. Because traditionally, self care has been defined by dominant culture and fed to us as a laundry list of to dos. I'm going to name a few and just see how you're feeling in your body when I say this. Good nutrition, sufficient rest, exercise, play, setting boundaries, socializing, massage, yoga, manicure. And while it may be beneficial to include as many of these components as possible in our routine and daily life, there's a limitation. They are off the job. So we sometimes use self-compassion as a proxy for self-care, but they're actually really different concepts. So self-compassion is really regarding yourself compassionately, whereas self-care, by contrast, is treating yourself compassionately. So there's a being versus doing distinction. So people can go through the motions of self-care without having any self-compassion. And similarly, you can view yourself compassionately and still not take care of yourself. So the two concepts, they really have to work together. Self-care without self-compassion discharges a debt. It causes suffering somewhere else in our physiology, in our body, and it can still lead to overwhelm and exhaustion. I know how that goes. You probably know how that goes when your self-care list becomes another to-do, an opportunity even for shame or judgment. Like, I didn't do the yoga class. I didn't do the meditation today, so now I'm going to judge myself for it. Self-care with self-compassion is a gift. It doesn't have to be earned or repaid. And it's a kind of like a muscle. The more we practice it, the more we build it, the stronger we get living with it. So when you support yourself with self-compassion, you have more emotional energy to keep going. You can make mistakes. You can unlearn and relearn because you know that your mistakes are almost more like a gift. And Paul, I know you know this, and Amy too, is that there are 3,000 studies that support the conclusion that self-compassion is like an emotional oxygen mask. So it's how you connect with yourself in this moment to handle a stressful, painful, difficult interaction at work, tantrums with your kids. You can't just run off in the middle of a workday or a tantrum to a yoga class or a difficult interaction at work. Self-compassion is really how you sort of pause with yourself in the moment and acknowledge your suffering. And I just have to quickly talk about acknowledging your suffering because I think it's the key component that's missing in this whole discussion around injury and distress, is pausing to turn toward and name how we're feeling. So in order to experience joy, we have to name our suffering. And in our culture, we are constantly being pushed to move past it, the next thing on our agenda, the next schedule. We don't need to belabor it. We don't need to wallow in it. But the more we're able to turn toward and say, I, Thekla, am struggling in this moment, or to validate, Amy, that you're struggling in this moment, to model it for others, the more likely we're able to pause and do that in the future. And I'll sort of talk about how pain and discomfort and distress is really unpacked suffering. We just haven't been taught in our culture how to name our suffering. And when we name it, we tame it. We can actually decrease it by getting it out of our bodies, out of our mouths, out of our brains, by just saying it out loud. Think about it in the workplace, even in your own workplace. Think about how often you hear people pause to just in the moment turn toward their suffering and to just name it. Not to fix it or solve it or go into that sort of mode, but just to name that it's there and that this too exists.
Yeah, I do want to ask you though, because I think you raise a very interesting point. Can I practice this in an environment that doesn't necessarily welcome or invite it?
Great question, Paul. So for me, because I work in systems like that, I've had to practice it on my own with myself. So I will speak to myself out loud. I'll go stand in the mirror, as uncomfortable as that is, and say it to myself. I do it in front of my children. I will name my suffering in front of my children to model the mirror neurons that it's valid, that it's there, that it exists, and I too can move on and coexist and I can operate despite my suffering, but that it's there and it needs to be validated. It's part of the awareness piece, what we call mindful awareness part of self-compassion, and it has some self-kindness in it. But again, I'll say that pain and guilt and overwhelm and resistance, that emotional reactivity, that's the buildup of unwrapped suffering. And we can't truly know joy until we acknowledge our suffering. They're like butter and sugar for all the bakers on the phone. You can't have too much of one without the other. You can't see the beauty in your home if it's filled with trash. You have to take the trash out. We have to do that in our bodies too. We have to let the suffering out.
I'm really hearing this balance, which is sometimes a trigger word for some of us too, in terms of what does it mean and what's the right recipe. I think it's really what is the right recipe to balance the individual and the system, the compassion and the advocacy to some extent as well. As we are kind of wrapping up our conversation, Thekla, could you talk a little bit about what this kind of work is like for you and your humanity?
It's a good question. And it's funny, Amy, I often introduce myself as an imperfect human because, hey, I don't have it all down either, but I'm practicing and I'm trying and I'm unlearning. And it's within that practice that I'm seeing these micro moments of it shifting my humanity. So I believe that the healing power of human connection is, as I said before, not feeling alone in your own story. So I've worked for almost 15 years in some of the most stigmatized areas of medicine, in addiction, in abortion care, in the criminal justice system. And I believe that healing comes from this sort of mindful awareness of our own human experience, turning the self-kindness that I give to you, Amy, and to you, Paul, as friends inward towards me, towards Thekla, which, let me tell you, I was not ingrained or trained in my culture of upbringing, and acknowledging my own common humanity, that we're all imperfect and this is part of the human experience, that I'm not suffering alone. I'm really passionate about this idea, Amy, about dismantling the hierarchy of humanity so that everyone can bring their whole self and their whole sense of purpose and their insight from their own lived experience, because lived experience is really expertise in your own healing and flourishing. And I can't speak on behalf of every provider in every system, but I know that we all have this strong desire to be seen, to be heard, to be loved, to be cared for, no matter where we are in our work life or in our healing and recovery process. We don't want to suffer. That's part of human nature, right? We don't want to suffer. We want to wake up to the reality that our systems, and I say this again, our systems may be causing the very suffering we seek to avoid. So I'm willing to show up to acknowledge how I may be contributing to unjust or unhealthy systems and how I can be a part of modeling, really, really modeling that compassion and self-compassion for the future, because it's within our mirror neurons that we actually do what we see. So if I see my boss modeling self-compassion, I'm more likely to do it. If I model it for my kids, they're more likely to do it, for my partner and for myself. Like, I give myself throughout the day many opportunities to make a mistake, to say, oh, I didn't turn towards myself in that moment to practice self-compassion. But guess what? I have another opportunity in the next moment, and then the next moment. So I'd say the answer is really, truly connection. I think Vivek Murthy would agree with me in his book about isolation, our famous Surgeon General. So naming our feelings, saying that our suffering matters, telling our stories, which I know you all are going to do in this beautiful podcast with folks with lived experience. Get it all out of our bodies, take out our trash, take out this suffering of trash. And for all the physicians who are listening, I mean, they took an oath to put other people's needs before their own. So I want them to hear me say that you can't keep providing unless you practice putting loving kindness towards yourself first. I truly believe, and you can quote me on this, that self-compassion is the ticket to sustainability. And I'm not enabling the system by saying that. I'm saying it's not our faults. We deserve loving kindness. We deserve a system that is invested in us and our well-being. But if they can't give it to ourselves, it is your birthright of human beings. You can give it to yourself in each moment that you practice. When you feel this sort of need to, quote unquote, somebody tells you you need to be more resilient, you can say, actually, I need more help. And when somebody tells you you need to be more disciplined, you can say, actually, I need more loving kindness, self-kindness towards myself.
Amy, I'm feeling like I'm getting a better sense of what we're talking about here, and especially why moral distress feels like a better naming than burnout.
I agree. I think this idea of imperfection, and Thekla, you said this so nicely today. If you can identify as an imperfect human, I think it gives us a little bit of permission to play in this space imperfectly.
I feel like we're at the trail. So I live in Colorado. I feel like we're sitting at the trailhead, and Thekla is our guide. But Amy and I are heading out on our own on this journey into moral distress. And we're going into the wilds here. Thekla, what parting words before we set off on this journey do you have for us?
Oh, that's beautiful, Paul. I can picture us on the trailhead together. And I would lean towards you both with loving kindness in my hand on your back. And I would say, trust yourselves. It's within you. It is within you. You are experts in your own lived experience. And you'll be hearing stories from other beautiful souls who are experts in their own lived experience. And I think the gift you're giving the world by having these conversations is to get it out of our bodies and to talk about it and to name the suffering and allow that to be seen and heard and validated and not skipped over because there's too much going on or because the organization or the system has something else that needs to, quote unquote, get done or do. Honestly, I think you're on this beautiful journey on the trail of just acknowledging that you're human beings. Notice I said beings, not human doings, and that you get to be in this process together. So enjoy, you both. Call me if you need me.
I'm huge into words. In fact, I love etymological dictionaries. And so I looked up the word health just out of curiosity. And the origins are from wholeness. What I'm hearing in the lived experience stories is a fracturing going on and a loss. And this idea of bringing wholeness back, not just the individual, but the relational aspect of this work with patients, and then also through teams and through organizations. We need to bring back the wholeness of relationship. And that's what sounds like it's been missing. I do want to recognize that in this podcast, when we are exploring some really challenging, painful experiences, that one thing we're not going to be necessarily taking on is looking at someone who does have, it's crossed over a threshold into a mental health condition. And if anyone's having any thoughts of self-harm or suicide, please make use of 988 calling or texting. And that what we're talking about in this podcast doesn't preclude seeking out professional help. You deserve to feel better. So whether that means getting some treatment or seeing a mental health professional, I just think it's important that we put that out there.
I agree. And I think that what we really aim to do is to develop this toolbox for clinicians out there and maybe even for ourselves as we embark on this journey, but thinking that mental health care can be one of those tools in the toolbox as well. And hopefully each week we'll pick up an invitation for us to move one step closer to reclaiming humanity or finding that balance.
Also, in each episode, we want to give you something to consider, to play with, to do. And one thing that I did hear Thekla talking about was this difference between self-care and self-compassion, and recognizing that self-care can be a burden, something else I have to do, typically outside of the workday. Self-compassion is really, how am I showing up for myself and others in the moment? And Christine Neff has done some amazing research into self-compassion. There's 3 components. And again, Thekla mentioned these, but I want to spell them out. And so there's 3 doorways into self-compassion. One is mindful awareness, and this just is checking in. How am I feeling in this moment? Honoring my full human experience with all the joy and suffering within that. Then there's self-kindness. And, if we think about some of the ways we talk to ourselves in our head, we'd never talk to a dear friend that way. So it's bringing some kindness in how do we talk to ourselves. And then Thekla also talked about this idea of common humanity and recognizing that sometimes when we're suffering, we're just going to close in and think it's only me. And that this opportunity of turning outwards, that I'm not alone in this pain and suffering. Thinking about what Thekla shared on self-compassion, and that motivated me to see, where am I at right now? And I want to share with our learners a quiz that both you and I took. And so in the show notes, we put a link to a self-compassion quiz to get a real good sense of, where am I starting out on self-kindness, mindful awareness, and common humanity.
Thanks, Paul. I really liked that quiz as a starting point for this journey to think about, what muscle groups do we need to practice amongst those 3 areas. And for myself, I had one to practice around self-kindness. And I think you mentioned you had another one.
Yeah, I was a bit surprised and a little humbled on common humanity. I came up as an area, I was going to say I came up short, but that's self-critical, so I can't say that. An area that I need to put a little more attention and effort into.
So I'd like to think about our journey together as a bit of compassion for ourselves and for others, knowing that there's no 100% on this quiz.
True.
But it just helps us to think about what we want to listen for as we have the conversation and listen to the conversation as well.
Yeah, maybe think about in terms of balance. Where am I in balance? Where am I out of balance when it comes to self-compassion? This is a huge systemic problem. I want to, make a pact that neither of us are experts. We're learning and journeying along the way here. And we're going to be hearing so many different stories that, to our listeners, we're going to learn together. And this may be a scary exploration at times, and you take it at your own pace. I got to come back to that metaphor, Amy. We're at the trailhead and we don't know what all is ahead. We've packed as best as we can. And may we grow and learn and give back to people that are working hard out there.
All right, Paul. All right, listeners. We've got our bags packed and ready to start on this journey. Whoever's editing this, throw in some dramatic music now.
Amy, I'm sorry. I've either got bluegrass or a banjo in my head right now. I don't know if that's quite dramatic, but let's do this.
We'll learn how to talk about burnout, other words we might use that feel less blaming to the individual. We'll figure out how to be kind to ourselves and work on that self-compassion, as well as we figure out what we need from our community, our employers, our colleagues, our friends, and our family.
See y'all again next time.
See you next week, Paul. If you'd like to reach us, you can do so at podcast@psychhub.com. To be notified of new episodes, don't forget to like, subscribe, or follow wherever you're listening. And reviews are so helpful, so please do leave one if you can. It allows others to find us and to join along. The Burnout Antidote is executive produced and edited by Jacob Morrison. Research is assisted by Thekla Ross. Show artwork was created by Ornella Jangoli and Ashton Smith. A very special thanks to Juliana Castro, Alyssa Fackler, Trevin Stiegel, Andrea Womack, and of course, our pet, Pickles. The Burnout Antidote is a co-production from Psych Hub and is brought to you by Janssen Neuroscience.